do it. Yeah, we have renal and GI to cover today. Okay. So we're gonna cover the bases of them. GI has a lot more, of course. We know the gastrointestinal tract is a lot more. Renal, not so much. The amount that you need to know about renal, not so much. You need to know the basics, and I'm gonna go over. So if you see me skipping slides, it's because I really just need you to know what I need you to know, okay? So that we can go on. As you go further into your courses, you're gonna get more in depth, but I need you to know the basis of these things. So we're gonna go through those today, okay? So, so guys, the kidneys, they have several functions. And some of those functions is hormonal. And what are the hormones that we can think of from the top of our head? That is renin, cortisol. Remember, cortisol comes from that.
Yeah, I do.
So renin. What else?
Aldosterone.
No, aldosterone is also from the adrenal.
Oh, it's wrong to say.
Renin, erythropoietin. And this is my fault that you don't remember this because I have a hard time remembering it. It's D125 vitamin, hydroxy vitamin D. Yes, and that's my fault. When I remember it, my students will remember it, and I'll put it in my head so I remember it. And it's right there, dehydroxyvitamin D. Okay, involved in the metabolism of calcium. The kidneys is also a waste monger, so it helps the body get rid of waste. It helps the body balance water and solutes, okay? And also conserve nutrients, okay? We're gonna talk about how blood goes through the kidneys and how we get our solutes back. Performs gluconeogenesis in the event of extreme starvation. And it usually synthesizes glucose from amino acids when it does this. And forms urine, of course. So this is their renal system. And just so I don't fall. Okay. We have the kidneys, and we have the suprarenal gland, which is the adrenal gland, which we talked about before. The right kidney is a little bit lower than the left kidney because of the liver, kind of pushes it down a little bit. You have the aorta and the vessels, the renal arteries come off of the aorta. And then there are renal veins, which also send blood back to the heart to actually be oxygenated again. You have the urethras. We have both, two urethras. And the male's urethras are longer than the female urethras, okay? That's why usually if you see a male with a urinary tract infection, you worry more than you see a female, because our urethral systems are much shorter in the female than it is in the male. And then you have the bladder, which is there, and then you have the urethra, which is, again, longer in the male than it is in the female. I'm sorry, ureters, not long, but the urethra is longer in the females than it is in the males. Settles around the 12th rib area. I'm sorry. What you have? You have the anatomy of the kidney inside. You have the renal cortex, which is the outermost part. I'm going to point over here. You have the renal medulla. And of course, you have the vasculature that goes into the renal system. And then we're going to talk about the renal nephron. The nephron is the basic functional unit of the kidney. And the nephron, if you look at it, we have several million nephrons in each kidney. And what it really does, we have several types. We have the superficial nephron, you have the mid-cortical nephron, and the juxtamedullary nephron. The superficial and the mid-cortical we don't really worry too much about, but the juxtamedullary nephron is the one that does most of the work, okay? And it extends deep into the medulla, and really this is what is involved in concentrated urine. So when we're talking about the concentration of urine, we're not talking about the other two nephrons. We're only talking about the juxtamedullary nephron in in this class at least, okay? Nephron is made up of the glomerulus, and the glomerulus is a whole bunch of capillaries that is actually tucked into like a little ball. It sits in the Bowman's capsule, in the Bowman space. And then you have mesangial cells, which basically like to support the glomerular capillaries, and which we're going to talk about in a little bit. This is what the nephron looks like. This is Bowman's capsules right there. You have the Bowman's capsule, which has the nephrons in it. This is basically the entire nephron. And if you look at the nephron, you have a billion of these that are functioning at one time doing the same exact thing, okay? Blood goes into the nephron through the afferent arteriole, and then comes back out and actually goes into the Bowman's capsule to go into this area right here through the afferent arterioles, and then comes back out to the efferent arterioles. And we're going to talk about it a little bit in a few minutes. All right. Glomerular endothelial cells synthesize nitrous oxide. They have all these other things it does. Endothelial is a vasoconstrictor. We've talked about these before. The juxtamedullary apparatus is basically what we're gonna focus on. And in the juxtamedullary cells, you have these specialized cells located around the afferent arteriole, which basically is what we use to secrete or reabsorb nutrients as we need to from the body. The macula densa is a group of cells that actually is a very bunch of cells that are arterioles that are across the nephron, goes across the nephron, and basically sends sodium and pulls sodium back into the periphery. This is your juxtamedullary apparatus. Okay. This is very important. Blood flow through renal arteries, and we're going to talk about it a little really fast. I don't really want you to focus on this. I'm going to tell you what I want you to focus on. This is not it. So blood comes from the renal artery, goes through a segmental and to the interlobular arteries, down to the articular arteries, interlobular arteries, and to the afferent arteriole. From the afferent arteriole, it goes into the glomerulus, glomerular capillaries, and then in the glomerular capillaries, and this is what the glomerular capillaries look like, okay? So from the glomerular capillaries, it goes basically into the pretubular capillaries and the vasorector. The pretubular capillaries look like this, okay? And if you look at the nephron that I showed you a little while ago, I'm going to go back and forth to the pictures, because this PowerPoint I preferred it was a little bit different. But this is what the nephron looks like. And the pretubular capillaries go all around it. So if you see, when we're talking about reabsorbing and getting nutrients, this is what nutrients are being reabsorbed and secreted from. This area right here. So what you have basically is this nephron that blood comes into these capillaries. And when blood comes into these capillaries, it is actually taken through into Bowman's capsule, into these capillaries here, and then it actually about 80% of the blood is going into the renal tubules. Only 20% is actually going through each nephron. So the 20% that goes through the nephron basically comes back out into the afferent arteriole. And if you look at how these the vasorector here is surrounded by the renal tubules, actually is surrounded by the vasorector. This is how blood is secreted and reabsorbed into the kidneys or into the body so that we can be excreted. I'm going to talk about it a little bit. I'm going too fast, and I know, but I don't want you to get hung up on it. So, again, you have the interlobular arteries, then it goes into the venous system, which actually takes blood into the renal vein, take it back into the inferior vena cava and back to the heart to get oxygenated again. So, the interlobular arteries, I really don't care if you know where they are, but they travel down the renal columns between the pyramids, and the articulate arteries arch over the pyramids the same way. The glomerular capillaries, which I'm going to saying the whole day, basically feed into the afferent arteriole. The afferent arteriole is basically what takes blood around those pretubular capillaries. So blood goes into the efferent arteriole, it goes to that little bundle right there, and then out to the afferent arterioles and down the precapillary membranes. So those precapillar or pretubular capillaries is basically where all the exchange is going to take place. Okay, so these pretubular capillaries surround the proximal and distal convoluted tubules and the loop of Henle. When we look at the nephron back here, you see the nephron starts here. So you have the afferent arteriole, it takes blood in. Okay, this is basically the tubules here. And you have the proximal convoluted tubules. Proximal usually means it's closest to. You have the distal convoluted tubules, which means it's further away from. You have the descending loop of Henle, and we're going to talk about why it's important. And then you have the ascending loop of Henle. You also have the distal convoluted tubules, and then you have the collecting ducts, which we're going to talk about again. You have the vasorector, which is that network of capillaries that forms the loops around the loop of Henle, and then the renal veins. These are the renal veins and the renal arteries. Now, when you look at what the kidneys do, they actually filter, reabsorb, secrete, or excrete. And this is where students usually mess up most of it, okay? So filtration is basically the blood going into the glomerulus. And when the blood goes into the glomerulus, it's substances or ions, all the stuff, sodium, potassium, water, bicarbonate, all these things are filtered into the renal tubules, okay? And then you have tubular reabsorption. Well, if we let all our sodium go into the renal tubules, we're gonna pee it out. So how the vasorector works is basically those pretubular capillaries kind of reabsorbs the sodium. It reabsorbs the water, whatever the body needs. So at different stages of the renal tubules, water is reabsorbed. Different stages of the water, the renal tubules, water is, sodium is reabsorbed, bicarbonate is reabsorbed, calcium is reabsorbed, potassium is reabsorbed, and then there's a certain part of the renal tubules where you see bicarbonate is excreted or secreted, meaning secreted or going for excretion, okay? So when you hear reabsorb, think of it as the body's taking it back, okay? When you hear filtration, think of it in the Bowman's capsule or juxtametrial apparatus, and it's basically just taking out what the body needs, and it's going through this process of taking back the majority of what the body needs, and it still has these ions that goes through the filtrate. Now the ions that go through the filtrate, it still has substances in it that the body needs. Most of the substances in it that the body needs is going to be reabsorbed. There's only a little bit of it that's actually going to be secreted and excreted as urine. So what we're looking at for tubular reabsorption is what the body's taking back. Then we're looking at what tubular secretion is, what the body just transfers to another place or just puts back into the renal tubules for excretion. And excretion is finally what you pee out at the end, okay? So these are the terms that I really want you to focus on. Because when you say something is reabsorbed, I want you to understand that that means the body is taking it back, okay? That it's going back into the body, it's going back into the arteries, the body is taking it back and the body is using that nutrient, okay? If I said it's being secreted, that means at that level, the body is letting it go. It's coming out and it's actually being prepared for excretion, okay? And then excretion is what we actually pee out. Now we know we excrete some water, we know we excrete some sodium, we know we excrete some urea, but we know that our body actually reabsorbs some of that also, okay? The only thing the body does not reabsorb is,
The only thing the body does not reabsorb is
Creatinine. Thank you. Always to my rescue. Love it. Sorry, I just had a really crazy morning. Breathe. All right. So, glomerular filtration. What do you call it? What goes into the filtrate? There are a lot of things that the glomerulus cannot filter out. Protein is one of them. If the glomerulus is filtering protein out, it means that the glomerulus is damaged, okay? The basement membrane for the glomerulus cannot filter out proteins. They're just too large. So if you see protein in your urine, know that something's wrong, okay? Glucose also should be reabsorbed. You should not see glucose in the urine, okay? So if you're seeing protein and you're seeing glucose, know that something is wrong. Something is spilling over, something is causing too much of something. So the kidneys or the glomerular basement membrane is damaged, okay? So size and electrical charge are important, and that affects permeability. Because we know we actually have to maintain homeostasis. So we have positive charged ions and negative charged ions, and that will actually keep the hydrostatic pressure balanced. If it doesn't, then you actually lose too much. In the case of, when we talk about glucose going through the basement membrane, we know that if the basement membrane is overwhelmed with glucose, what usually happens is that we'll have glucose spilling out into the urine. Why will we have glucose spilling out into urine? Because we're going to have this majority of positively charged ions that the body can't filtrate out because it's overwhelmed in the glomerulus, okay? So capillary hydrostatic pressure depends on the amount of the right amount of solutes and the right amount of water. Water moves through the glomerulus through water and actually solutes move through diffusion. So if you think about it, diffusion of particles move from an area of lower pressure to an area of higher pressure, and water from the opposite through osmosis. When we're dealing with diffusion, we're not dealing with osmosis here. So when you're thinking, think of solutes moving from an area of lower concentration to an area of higher concentration. So wherever the concentration of salt is higher, that's where the water is going to go, where the salt is going to go to. Okay. So filtration rate. Filtration rate is about 180 liters per day for approximately 120 mLs per minute, okay? And this is basically what we're looking at when we're looking at our glomerular filtration rate. If someone has a glomerular filtration rate of 30, that's a really bad thing, because normally you should have at least 180 liters per day. Okay, your rate should be 120 mLs per minute. If your rate is 30 mLs per minute, that is a bad thing. Okay, so you want to look at that. Blood. Blood is a really large protein, and blood should not be in the urine. If blood is spilling over in the urine, something is wrong. Okay, so when you're looking at proteins in the urine, any blood in the urine, any large protein in the urine is a bad thing. That tells you that your basement membrane is damaged. Okay? 99% of the filtrate is reabsorbed into the pretubular capillaries and returned to the blood. So that means it's only 1% of the filtrate is actually gone. Okay? And that filtrate is what has our sodium, it has our bicarbonate, it has our potassium, it has all those ions in there for our body to actually reabsorb what we need, take it, and then leave the rest, okay? You can answer the questions, they're all there, okay? So, tubular transport, approximately 60 to 70% of filtered sodium and water, and approximately 50% of urea have been reabsorbed, along with 90% or more of potassium, glucose, bicarbonate, calcium, phosphates, amino acid, and uric acid. Okay. When do you think we're going to secrete more bicarbonate? No, if we're acidotic, we need to reabsorb more bicarbonate. We don't need to secrete more. If we're too alkalotic, we're gonna reabsorb, we're gonna actually excrete more. Okay? So if you're secreting bicarbonate, it's because we're too alkalotic, okay? If we're reabsorbing more bicarbonate, it's because we're acidotic, okay? Same thing. If we have, our amino acids, our body breaks down amino acids to where it actually can be reabsorbed or it can be filtered into the glomerulus. The amino acids, our body needs amino acids because that's how we build cells. We should not be spilling amino acids into our urine. It should be reabsorbed. Most of it should be reabsorbed. Calcium phosphate, the same thing, okay? So, hold on. Knowing what is reabsorbed tells you which medications work on what, okay? So I'm gonna let you read these on your own, because it's easy.
I have a question. When you do the keto diet and you excrete ketones, what does that mean?
Well, ketone is a byproduct of fat metabolism, okay? Yes, so if you're using fat, if you're metabolizing fat for energy, the byproduct of fat metabolism is ketones, okay? So that's where you usually get it from. Okay, so the important thing of knowing what comes out where, what is reabsorbed where, what is secreted where, is basically knowing how meds work. So if I tell you that the loop of Henle, concentration of urine, water reabsorption, sodium diffuses in, ascending loop, if I tell you the descending loop reabsorbs water, and the ascending loop, sodium is reabsorbed, that tells you what? If I give a loop diuretic, what am I doing?
Instead of absorbing, you're gonna secrete.
Where does it work? On the kidneys. It works on the loop of Henle, okay? Because if it works on the loop of Henle, it actually is causing you to do the opposite. It's causing you to excrete sodium and excrete water. Because they're actively reabsorbed on the loop. So if I give loop diuretics, they're working on this area right here. Okay? Now where do thiazide diuretics work? Distal tubules. Reabsorption of sodium. Okay? The proximal tubules does the majority of sodium, but the thiazide diuretics still work on the distal tubules. And reabsorption of sodium here is where it works on, okay? And sodium, if this is damaged, sodium will not reabsorb here. So usually if we're talking about sodium, blocking sodium reabsorption so that we can lower blood pressure, we're gonna work on the distal tubules, okay? Now, ADH we talked about last week. ADH we said aquaporins are instilled into the renal tubules so that we can do what?
Reabsorb water.
Water, okay? So we know that ADH works where? On the distal tubules, okay? So we know that we insert those aquaporins into the distal tubules, and they actually allow for more water to be reabsorbed, okay? And it actually blocks sodium, as aldosterone is working on here. So you have your aldosterone antagonist drugs, you're gonna actually block sodium reabsorption here, okay? Your collecting ducts, reabsorption of water, ADH is also required, so ADH is actually instilled into the distal tubules and the collecting ducts. Reabsorption or secretion of sodium, potassium, hydrogen ions, or bicarbonate, okay? It depends on what our acid-base balance is. That's gonna affect our bicarbonate or hydrogen ion secretion. It depends on what our potassium is. That's gonna affect our potassium secretion. It depends on what our glucose is. That's gonna affect our glucose secretion. our sodium, it depends on what our sodium and blood pressure is, that's gonna affect our sodium reabsorption and secretion. The body takes what it needs and it does away with the rest, okay? So that's what basically the filtrate is for, okay? The juxtaglomerular cells, when did we talk about that before? We talked about the juxtaglomerular cells before, at some point. Secretion of renin, okay? So when does the glomerular cells secrete renin? The juxtaglomerular cells secrete renin.
There's low flow.
Low blood pressure,
Yeah, low blood
okay?
pressure.
So in the state of low blood pressure, we secrete renin. And then renin works with angiotensinogen and goes to lung, angiotensin 1, converted to angiotensin 2 with angiotensin converting enzyme, which works on the kidneys. Okay. I think that's all from this one that I really wanted to go through. And basically everything else we're gonna kind of talk about in the other PowerPoint. Urea is the end product of protein metabolism. It's a major constituent of urine. 50% of urea is secreted, 50% of it is reabsorbed. Okay, so it's recycled into our bodies. Catecholamines, renalase is an enzyme that actually breaks down catecholamines at the level of the kidneys to regulate blood pressure. All right, I think we're done with this. Everything else that I did not go over, guys, trust me, is in the other PowerPoint, or we've gone over it before. I just wanted to basically go through that really quick. Oh, what a urinalysis looks like. You guys should see this every day. Your urinalysis, your urine color should be clear to light yellow. The light yellow is from urobilin, which is broken down by the liver and the kidneys to actually excrete bilirubin. Urine pH should be between 5 and 6. Remember, your urine is very, very acidotic, okay? Specific gravity, it should be 1.01 to 1.02. If it's too high, it means that we have too much concentrates. If it's too low, that means it's too watery. Red blood cells, you should see few or no red blood cells, okay? If you're seeing large amount of red blood cells, it means that we have some kind of things wrong, okay? CAS usually means that there's some kind of infection going on, and usually it's some kind of kidney disease, pyelonephritis, you'll see CAS a lot, okay? Crystals indicate the inflammation or infection. White blood cells, again, there's infection, you want to look out for that. How do we do urinalysis? We usually don't use these reagent strips anymore, but they're there. You send it to the lab. Things that you want to look for in the urine: glucose, bilirubin, urobilirubin, leukoesterates, ketones, proteins, hemoglobin, and myoglobin. Aging and renal function, we know that as we age, our kidneys function decreases. A lot of times it's due to drugs we take, everything that we've used. We can have increased urinary retention or excretion, depending on what's going on. Actually, I skipped something that's not in the other slide. It's all gonna make sense in a little bit, guys, I'm sorry. All right. How do we pee? How's mitochondria? He can make my bad day much better. That's why I love him. He doesn't understand. He makes my bad day much better. How do we pee? What gives us the urge to pee? We've talked about
Bladder
this before.
distension.
Full bladder. Okay. A full bladder. When we have a full bladder, what causes the bladder to contract?
Parasympathetic, the
Parasympathetic nervous
parasympathetic
system.
system. Is it the
What in the
spasm?
parasympathetic nervous system?
Bladder's full, it stretches.
You have receptors,
Receptor, yeah.
okay? So which receptors?
Alpha?
We have muscarinic and nicotinic receptors, okay, from the cholinergic parasympathetic nervous system, okay? We also have beta receptors from the sympathetic nervous system, okay? Remember that bladder innervation occurs basically from the parasympathetic and the sympathetic nervous system. What does the sympathetic nervous system do to our urinary system?
Shuts it down. Relaxes.
It causes it to relax, okay? And when it causes it to relax, what does that mean? You do not urinate. Why?
There's
It
no,
causes what to relax, by the way?
your detrusor,
It causes the detrusor muscle.
detrusor muscle, so there's no like,
So
Move
I have a
pushing it
picture
up.
here of the bladder. Do I not? Yes, I do. Okay, so I'm gonna draw it myself.
Oh, one.
You're so nice. Actually, I just have a picture. Okay, so you have internal sphincters and external sphincters, right? And then you have the detrusor muscle. And these are the things that are basically innervated when we're urinating or if we're holding our urine, okay? So if we have the detrusor muscle, what works on the detrusor muscle?
parasympathetic,
You have both.
I mean,
You have muscarinic
okay.
and you also have beta 3,
Beta.
okay?
So muscarinic.
So you have beta 3 receptors, and then you have muscarinic parasympathetic receptors, okay? You have nicotinic here, and you also have alpha receptors here, okay? So if I have a patient and the sympathetic nervous system is taking over, the sympathetic nervous system will innervate the beta 3